Welcome to the CereCore podcast, where we focus on the intersection of healthcare and IT. From practical conversations to strategic thought leadership, let's unpack the decisions, challenges, and journey of those whose purpose is to deliver technology that improves healthcare in their communities.
Well, today we welcome Dr. Charles Bell to the CereCore podcast. Dr. Bell has been a physician advocate in healthcare technology for decades and was the Chief Medical Information Officer at Northern Arizona Healthcare and a physician informaticist at Catholic Healthcare West. Currently, Dr. Bell is a physician advisor for CereCore, providing physician leadership for electronic health record implementation and consulting projects in hospital and ambulatory care settings. Prior to joining CereCore, he was the Vice President of Advanced Clinical Applications for HCA Healthcare and served as a physician champion for Meditech 6, Epic, and Cerner. It's quite an accomplishment right there. Not many people can say that. Dr. Bell holds a bachelor degree in biology from Rider University, a bachelor's degree in pharmacy from Temple University School of Pharmacy, and a doctorate from Philadelphia College of Osteopathic Medicine. He completed his residency in general internal medicine at Phoenix General Hospital in Phoenix, Arizona. That is quite a mouthful, Dr. Bell. Quite a career. And so maybe we'll just start there. Really appreciate you taking the time to join us today. Maybe just tell us a little bit about your career, as a physician. Your role through, not only serving out in Arizona and HCA and then with us in CereCore, but then how you've kind of used that role as that bridge between IT and the physician community.
Well, first of all, let me just say I appreciate joining you and having the opportunity to speak on these topics today. My career actually started as a pharmacist, and I worked as a pharmacist for several years. I actually worked as a pharmacist all through medical school up until my final semester of medical school. So did a lot of research work and the like as a medical student. Did my internship of residency in Phoenix. And during that time, those are back in the days, and I don't know how often it occurs now, but I did a fair amount of fighting in clinics and the Indian Health Service and the VA. So I got a good education as far as not only private sector, but also government medicine. And once I finished my residency, I opened a solo practice in Phoenix, went from that to a larger group and then back to a small practice, and did that for about 10 years before I transitioned and became a hospitalist. Most of my practice time in Arizona was in the greater Phoenix area, but I did do approximately 6 years in northern Arizona, Flagstaff Medical Center and Verde Valley Medical Center. So was very familiar with that area of the state and a lot of the nuances of taking care of patients in that environment. Through all of that, I must say, even when I was in private practice in the mid-90s, I was doing electronic billing way ahead of the curve. You may remember, some of you who are listening to this probably don't remember or know about Palm Pilots, but I actually used the Palm Pilot program that was a medical program and had my patient roster and billing and things from that, probably mid-90s. So it was way ahead of the curve. And I am an avowed geek. Love electronics and gadgets, and so that aspect of it was a very easy transition for me. But that led to me getting involved in medical informatics long before the term was actually coined. And so I did a lot of the liaison work for physicians with IT, even when I was at Northern Arizona healthcare system, and that transition to Catholic Healthcare West. And so the interesting thing about the transition Northern Arizona, we're talking about 3-4 facilities, 2 hospitals, and a couple of outpatient clinics. That transitioned to Catholic Healthcare West at the time, had 44 facilities. And then I transitioned in 2010 to HCA, which, with the four rollouts that we had, the 4 sections that we did, there was one period where we did 52 hospitals. So the pilot was with 22 hospitals. So we really got adept at looking at how to match up what was needed for multiple facilities in different parts of the country that had different needs. And oh, by the way, this was ripping out a lot of processes and procedures and comforts for physicians, nurses, pharmacists, everyone in the system. So we got a lot of great experience working through the 160 plus facilities that we ended up converting during my time working directly with these facilities at HCA. So, and as it turned out, my last day working full time at HCA with CereCore was March 20th of 2020. And some of you may remember that on March 23rd, something very important happened. The whole country shut down. So it was starting in that time that it was really looking at what are the options? What are the options not only for physicians, but it became very apparent to me that there was a need for people in the community, patients and people in the community, and the needs that they would have. So that's been the transition that I've made, and went from really the core of bedside medicine, because as the bulk of what I did when I was in practice working in hospitals was very much intensive care, critical care. And I would always tell patients, my job is to keep you from seeing me at my best, because if you see me at my best, that means you're in a critical care unit somewhere.
That's right.
So, but anyway, that's the journey. That's the encased version of a very long journey.
I got to tell you, it is such a fantastic story and journey, and it's for me, in listening through all that, just to understand and try to wrap my head around all the different aspects of healthcare that not only have you had your hands in and been a part of, from the practice to smaller systems to massive systems, the largest in the United States, touching just about every EMR out there from a major EMR standpoint. Adopting technology before its time, before anyone had really even thought about some of those things. You have certainly, you bring a wealth of knowledge and expertise to us and to our audience. So really appreciate you kind of laying that groundwork and foundation. And I'm sure that you have seen throughout that process the change from really, you've seen this rise of technology, and then we went through meaningful use and just all of a sudden now the need for, everyone's got to be on an EMR, and what does that look like, and how, and the challenges that are faced, and, almost the shift a little bit from, physician led to, sometimes in certain instances, it seems like things are IT led. And that does tend to cause some challenges inside of the organizations, inside of practices that sometimes even unfortunately ripple down into the patient care. And so I think you've spent a little bit of time as kind of that liaison, right? Mm-hmm. And from the beginning to what you're seeing now, is the gap between physicians and IT, is it closing? Is there still a chasm? And I think that's probably where we're gonna spend a good chunk of our time, because you've kind of been in your career for a number of years trying to close that gap.
Yes.
For the betterment of the organization and for the betterment of the patient. And so, maybe we just start there, kind of where you see what that transition has looked like, and then where you see it standing today.
Well, I'll start by saying it's a forever cause for me, because I feel like first and foremost, I have to be a patient advocate.
Yes,
that's my role as a provider. But then there's challenges that we see as providers, and I'm going to use that term broadly because it's not only physicians, it's nurses, and it's pharmacists. It's for anyone who touches the system. Everyone is impacted by it, and that's the one thing when we talk about that overview of what you're getting when we make these changes. It touches everyone in the system, and so as far as the gap, I would say the gap has narrowed, but a lot of that is because the technology has changed so much. Technology outside of medicine. You can ask the question of a physician: when's the last time you walked into a bank to do any type of business? And the other part of it, when you get complaints about the system really doesn't work for me. When's the last time you got a smartphone and used it just as it was when you opened it up out of the box? When's the last time you got a computer and used it just as it was when you got it out of the box? So it really takes some investment of time by the individual, whoever that individual is. It takes some investment of time to really customize and really individualize that tool. And that's all it is. It's a tool to help them do what they have to do to care for the patient or whatever their duty is. And I think the biggest part, the challenge that I see, and I saw it on both sides because I spent a lot of time in the field, Phil, as you know, in the trenches at a lot of the facilities, a vast majority of those facilities that we took, onto a live status, I was there. And one thing I will also mention in that as a side, having worked with Cerner, Meditech, both Expanse and the current platform, and with Epic, I can tell you when I walked in the facility and I got complaints as to what the issue was, I could show you that list of complaints, but you could not tell me what system it was. The complaints were very similar, no matter what the system was. So that meant you have to buy into the process of how do I adopt this for me and get the most out of it. I can't expect it to do all the things that it was doing before, get it to do the things it was doing before when it's actually designed to do more than it was getting out of the old system. And the other thing I will say about that is most people who make the change to a new system, whatever system they leave, that was the greatest system that ever existed. Once you have to, after you move from it, you think, oh, well, it's not that bad. So let's talk about that chasm. The chasm comes in where, let's say as a support person, a physician calls and says, I can't find the x-ray that I'm looking for. I need to see this x-ray. And the answer to that physician is, well, we have a new program and we're working on it and it'll be ready and it'll be very easy for you to find that x-ray and we're rolling it out next week or next month. Well, the disconnect comes right there because it's not information I need now, it's information I needed 5 minutes ago. And now you're telling me I have to wait a week, a month, open-ended as to when I'm going to get that. And so it really it raises the level of frustration for that provider because a lot of times, you hear the question about, well, it's not life and death. Well, for a lot of cases, it could be life and death. It makes a big difference in getting that information because based on that information, I'm going to provide care. So with how remarkable the technology is, there's a difference from an IT standpoint where something is just the latest and greatest and really great, and it seems so, it just seems like it's just so automatic on how I can use it. It's easy. You just do this, and there's and it functions for you. Well, that doesn't work in the case of someone who is under pressure to find information right now. I can't remember this 3-step sequence to get the information. I need to have it so that I can remember, I can get to it, that it is automatic for me to be able to utilize that. So the divide comes in and the frustration comes in, whereas from an IT standpoint, I have this great functionality and I'm offering it to you. And then the other side is like, it's not great functionality because I need it right now and it's not available to me. So there's a divide. There's a divide. So what I enjoyed the most about what I did and what I continue to do is understanding both sides of that, to be able to have a conversation with the physicians to say, you went from a paper-based or you went from a system that did not function or give you the functionality that this system is allowing you, and you have to adopt to it. But you have to also understand that it's not a matter of just flipping a switch and making it work for you. It has to work for everyone. So having that understanding that you do have to have some patience, no pun intended, to get to where you're going to be using it. Now that goes back. I got to take it back. The part that I have to step back and look at is, I don't know any facility that does not give the physicians an opportunity to speak up during the build phase. I don't know any facility that does not give physicians the ability to participate in meetings, to be in a physician advisory group or physician advisory council. I don't know any facility that doesn't do that. But there's this attitude a lot, and I'm saying this as a physician, that we got this. Well, when you flip the switch, you don't got this. You know, right. You're going to have trouble. You're going to have difficulty making that transition if you don't put some work into it to begin with. Now, what helps IT is if you start at that build phase and you do a day in the life, you walk through what is my process? What is the process of the nephrologist? What is that process of the surgeon? How do they get to the data that they need to get to? When you do that walkthrough, you can make that build so that you minimize the hangups. You basically close that gap. But the other part of closing the gap is really being able to understand what it's like to walk a mile in that other person's shoes. And so
I think you're spot on there, because the physician journey, the schooling, everything, their focus is radically different than an IT professional. Mm-hmm. They come at the same issue. We need to implement a system from two totally different worlds, two totally different, mindsets, two totally different backgrounds, and in many instances, just total viewpoints. And so I think you're spot on, and just by the very nature of having two different groups of individuals, you can see where that relationship is going to be tenuous. Mm-hmm. Perhaps even, some might consider, broken or whatever. And so I do think that, you're spot on, and, maybe we can talk a little bit about that, right? How is it that, or what are some of the best practices that you've seen to, one, I think both IT and the physician community first have to acknowledge the differences and respect each other. Mm-hmm. And then how do they get to that collaborative fashion?
The starting point is to understand one thing. We're on the same team. That's the starting point. We're on the same team. You're on offense, I'm on defense. And so my role and my job is different, but without you, I can't get my job done. So I think just having that understanding of what the role and some of the process. And I'm not saying that we're going to turn IT folks into physicians and vice versa. We're not going to turn physicians into IT folks, but you have to have that understanding,
right?
Of better understand what is involved. That it's not a matter of just flipping a switch or making a quick change to to get something done. I sat on a lot of councils throughout my time at HCA and with CereCore, and a lot of decision making went into, we want it this way or that way. And it's really interesting because you can make a decision and a year later you have turnover, you get new people in that committee and they want it a different way. That's right. And you have to really document and show the reason why you made that decision. So having that as a core, first and foremost, we're a team. And secondly, this is why this decision was made, and have that historical aspect, that record, that track record of it really helps. But understanding what, the offense is doing and the defensive job, basically, as I said, as I started this comment, you have to understand that you're on the same team.
Yeah, I think that's it's great insight, same team working for the same goal. Just different roles. You're spot on, right? Offense, defense, they totally different, but at the same point, both incredibly critical to moving forward. So, as IT is interfacing and engaging with, physicians, what should they be listening for? What are some of those things that, maybe physicians would say in passing, or they might make assumptions? What is it that, that an IT person what questions should they be asking? What should they be truly listening for, so that chasm can close faster without some confusion?
This is a difficult thing to do because it taps into the core of human nature, but listen for the message. You have to listen for the message. When you have a physician, I'm the IT person, a physician is talking to me and they're screaming at me. I have to understand that I have to let things fly past me until I hear them say, and I had a problem logging in. I can work with that. The fact that you got up late and traffic was bad and I spilled my coffee, okay, that's important information because that's laying the groundwork for why the pitch of the conversation is where it is.
Right.
But I still need the details of what is going on before I can help you. And the fact that they got up late, there was too much traffic and they spilled the coffee has nothing to do with me as the IT person, right? So they can be venting. I can't take that personally. And that's the part that's difficult because we don't like people screaming at us. We don't like people being upset with us, but we still have to ferret through and get to the point of what is the issue. And I'll give you another example of how that happens. The doctor said, I don't have time for this. And a half hour later, they're still on the phone, still spewing, right? So you just have to pick out the nuggets of what is it that is the issue and what is it that I can help you with. And so from the standpoint of the person who is giving you the issue, they might not be able to tell you that there's a problem with single sign-on. They may not be able to tell you that, I left the session open somewhere. They may not be able to tell you any of that stuff. But in essence, they will. For example, I was on the other floor, I came down, I tried to log in and I had a problem. Well, they just describe to you the path of what you can say, okay, I know what the issue is.
Yes.
You can help them with that. And so that's the biggest aspect, I think, is just being able to ferret out all of the noise and really hone in on what are they actually complaining about. Now, this happens also, often as well. You may have one or two physicians, maybe a handful, who complain a lot at the beginning of right after go live or pretty early on. And then after a while, you don't hear from them. And the assumption is made that they're doing okay because I'm not hearing from them. But all too often, they're not calling anymore because you didn't help them. You didn't solve their problem. So why would I keep calling you? You're not going to solve my problem for me. Why would I keep calling? So I find a workaround. I find something else that works for me. And then that's where you tend to find where physicians aren't utilizing the system to its fullest.
Right.
And so it's really, the challenge is that there's a hierarchy, right? I, as the IT person, I'm not going to scream at the doctor, but as the IT person, I may get screamed at. And I just have to, like I said, let that noise pass and really hone on what the issue is that they're complaining about.
So as you think back on your career, and like you said, you've been through numerous of these before, can you think of a situation or two where the building of the relationship between IT and the physician or clinician community just worked out really well? And what were maybe some of those key things that they did, whether it be programmatically or intentionally, to build those relationships, to build that respect so that they could have those meaningful conversations to not only get through the project, but then to build that ongoing relationship? Because as we all know, these things aren't just a set it and forget it. They're living, breathing entities inside of the organization. So, maybe some things that you've seen that were just, what, every organization should do this. And then maybe a couple of things that you've seen that you're like, please, at all costs, avoid doing this.
So I'll focus on what I've seen from a successful standpoint. And then anything I say about the successful standpoint, you just avoid that. Okay.
There you go.
If you stay away from, as long as you do what's successful, then you're going to be fine. Because if you deviate, you're not going to be successful. And Perfect. So it starts early on, having input from the physicians. It has to be a team. You have to sit side by side. You have to have that multidisciplinary team so everyone understands what the other person's job is. For example, if I want the system to every alert, every medication alert, I want to go past me and let the pharmacy deal with it. Well, in those meetings, I would flip my hat and put my pharmacy hat on and say, pharmacists are people too. We don't want to be, we don't want the alert fatigue no more than you do. And so this is how we can find that happy medium, and going through a day in the life situation. And so, and allowing everyone who's going to be impacted by the system, see what it can do as you're building it. Looking at those milestones, not waiting until it's the time for training to show what the system can do, but because the whole point of the build is to get you to a point where the system is effective and useful. And that's what you want to get to. So you want to have multidisciplinary input. You want to have exposure to people, for people to see what the system can do, a direct line of communication and that with that communication, you're closing loops so that if a question or a problem arises, the answer gets back to the people who need to hear that answer. And then you have an effective rollout. You move with those things, you move to an effective rollout. But keep in mind, go live is like commencement, and it's called commencement for a reason. It's the beginning. Right. And so when you look at the effective system, you're nowhere near being able, let me put it a different way. That system is nowhere near being used to its fullest extent. And so when you start looking at optimization, that doesn't mean you're bringing in new functionality. That means that you're capitalizing and utilizing the available functionality to its fullest.
Right.
And so, but you're not going to have that if you don't walk the walk all the way up until, the starting line and then go beyond.
You make a good point. It's hard to, once physicians have checked out, it's hard to get them re-engaged without a lot of meaningful change that goes into that. And I think you touched on the commencement angle and kind of moving forward, and certainly above and beyond the EHR. There's so many other things that are tied to technology that are coming down the pipe, that we're all looking at, thinking about, getting bombarded with on a daily basis. It started with kind of the, COVID and telehealth, and then, this concept of wearables for the patients, hospital at home. Now we're talking about AI. We were at HIMSS and everyone was talking about AI and ChatGPT, and the list goes on and on and on. So how, in your perspective, how should, the clinician, the clinical community, physicians, you name it, and IT be looking at all of this together and really kind of, what would be your guidance as far as, maybe structure and process to determine, hey, what should we be looking at? What should that process look like? What's going to be the ultimate end result for the patients, just from a collaborative standpoint?
So I think let's start with AI, because a lot of that technology has been available, even if you look at type ahead functionality. You put in 3 letters and the rest of it pops up.
That's right.
There's things about it. The same thing with using speech to text, which, I spent a lot of time in the arena. There's a lot of things about AI that have been there, but it's gone to a whole nother level. And then you think about how it helps with diagnostic, looking at diagnoses or patient care. There's a lot of aspects with billing. Every aspect of what you need to do as an organization, AI can definitely help and has been. It's just going to a whole nother level now, to the point where we're worried about Frankenstein. But there's a lot of issues that it solves. But you have to start with pointing out the things that the system is already doing, and we're talking about an extension. You talk about the smart rooms, where you just have the microphones and you talk, and it ferrets out what the patient says and what the physician is saying. Well, that's not new technology. That's been out there.
Oh.
You talk about telehealth. Most people don't realize that telehealth has been a thing since early 1950, 51 or 52. Why wasn't it so broad? Because there was one reason why telehealth never caught on as a mainstay in taking care of patients, and it's because you couldn't bill.
Yeah.
And so the pandemic changed that. So the whole landscape has changed. And so really embracing the tools, embracing the change, the new paradigm, it makes a difference in looking at what the system is capable of. But doing that, sometimes you have to point out what it's already doing. That's a transition from what you were doing a year or 2 or 5 years ago. You are making that transition.
You're spot on, because I think what you're touching on too is a little bit about what we call about application creep, where all of a sudden it's like, wait, we actually have this capability. You're just not either aware of it or not using it, and so consequently, then you look a couple of years down the road and you're like, well, I've got these 3 things licensed that do the same thing, more or less. So, I think you're spot on in that. Those physicians that get excited about this stuff, and the IT folks that get excited about that, they need to be all on the same page and giving that kind of honest assessment throughout the process around, all right, what should we be doing? And taking a look first internally to say, all right, is this already available? And then if not, strategic path forward. So no, I think that's spot on. So, I always love to wrap these, Dr. Bell, with just kind of an open-ended question to you. And that, and that is, most of our listening audiences are in the IT space and CIOs. So from a, physician perspective, from a perspective of someone who has played that translator role, for years and years and years, what are maybe the top, couple things that you think every CIO, every technologist should know as they deal with the clinical community?
So I think the biggest part that helps is understanding what is actually involved in the workflow, in that workplace. So even if it means getting out and shadowing a physician, or sitting on the floor, sitting in an ICU and seeing what happens, it works. That does 2 things. There's processes that you come up with that you can see how they actually work in the real environment. Or the other aspect of it, you see how it's an encumbrance in the real environment. And you may say, aha, I know how to cut that down from a 3-step process to a single click, or at least get rid of one of the steps. And that makes it more intuitive. And so From the standpoint of really getting a better understanding of the impact of what's going on, you have to get into the trenches, even if it's looking at it, from behind the glass, so to speak. Back in the days when they had the amphitheaters and you can look at what's going on in surgical suite, it's really getting to see the impact at the level that you want, that is needed. Yeah. Because going back to the team concept, if I can do something as the trainer that's going to help that player to do better, then I've helped the team. So if I do that, but I don't know, if I sit in the training room all day, I don't know what that player's doing. I get out on the field and see what they're doing, so to speak, then I know what they're doing. I don't have to go out on the field with them, but I can see something that I can help them with. Yeah. So that's what I would recommend, and I think works best.
No, that's spot on, and I think whether you call it walking a mile in their shoes, or whether it's we call rounding, or whatever it is, whatever terminology, I think you're absolutely spot on. It's you have to take the time to gain the knowledge, to understand the other person's perspective, to understand the other person's world. And otherwise, without that understanding, you're going to be missing in conversation and dialogue and execution. So, Dr. Bell, fantastic words of wisdom, and thank you so much for not only the years that we've been working together, but also for joining the podcast and for your insights for our audience today.
It's absolutely my pleasure. Appreciate the ask.
Excellent. Well, thank you very much.
Right.
Thanks for listening to the CereCore podcast. If you like this conversation, check out our other episodes. Visit us at CereCore.net to learn more about our IT services and connect with us on LinkedIn. At CereCore, we are healthcare operators at heart and know the difference that the right IT partner can make in delivering quality patient care 24/7. Let's help make IT better. Here's to the journey.